ఒకసారి చూస్తారా
దాంట్లో
సార్ మళ్ళీ బ్యాక్ వెళ్ళి సార్
కాదు ఆ ఒక ఫిగర్ దీన్ని పెట్టిస్తావా ఇది ఉంది కదా ఒక నిమిషం చెప్తా ఇది ఎప్పుడు వస్తుంది ఇట్లా రాదా ఇట్లా పట్టుకున్నది ఎనికి కాదు కిందికి
కిందకి కదా సార్ మొత్తం
ఆ మధ్యలో బొమ్మ బయాజు ఇంకా పైన ఈ బొమ్మ దాని మీద పెట్టించాడు
డెస్క్టాప్ మీద అది అది నాకు సార్ అది సార్ కృష్ణ చేస్తాడు
సరే వదిలేసి నేను మళ్ళీ ఇట్లా ఓపెన్ చేసుకుంటలే లాస్ట్లో ఓపెన్ చేసుకుంటే ఏం కాదు
మీ దగ్గర ఉంది సార్ లింక్ మీకుందా
లేదు నేను పెట్టుకోలే
నేను ఆల్రెడీ స్టార్ట్ చేసాను సార్ ఆల్రెడీ స్టార్ట్లో ఉంది స్ట్రీమింగ్
ఓకే So today's class is urinary bladder, urethra, ureter and skin as excretory organ. First we come for the urinary bladder. Urinary bladder is a hollow viscous which acts as a reservoir of urine. Hollow viscous, that means an organ which is empty. Hollow viscous, that means an organ which can accommodate something. And then it acts as a reservoir of urine. In adults, it is a pelvic organ when empty. In adults, it is pelvic organ when empty. That means when the bladder is empty, it is within the pelvis only. And of course, when it is full, it can occupy the lower part of the abdomen. And the bladder neck lies just above the plane of the lower border of the symphysis pubis. So it is a pelvic organ. Its lowest point, that is the bladder neck, lies just above the lower border of the symphysis pubis. Then its capacity is 120 to 320 ml. The urinary bladder capacity is 120 to 320 ml and the mean capacity is 220 ml. In normal adults, it ranges between 250 to 450 ml, whereas in newborn, it is 20 to 50 ml. So that's about the urinary bladder, where it is and what's its capacity. It is behind the pubic symphysis. Its lower level is just above the lower border of the symphysis pubis, and of course, when it is empty only, and if it is full, it can occupy the lower part of the abdomen also. Then it is having 250 to 450 ml. It can accommodate 250 to 450 ml urine unit in adults, whereas in children it is about, in newborn it is about only 20 to 50 ml. Now shape, it is tetrahedral. Tetrahedral means a triangular pyramid with 4 triangular faces. It is tetrahedral when empty and oval when distended. So when it is distended, it will become a oval shape. No angles, all angles will be gone. So this tetrahedral shape will be having 4 angles, an apex, a neck and 2 lateral angles. 4 surfaces, superior surface, base and 2 lateral surfaces. 4 borders, anterior, posterior and 2 lateral borders. So this is the tetrahedral pyramid, wherein we are having a superior surface, a base and 2 lateral surfaces, one on this side, one on the other side. And now we are having the border between the superior surface and base. This is the posterior border, and between the 2 lateral surfaces, anterior border, and between the superior surface and lateral surfaces on either side, that is 2 lateral borders. So this is the figure of the bladder, which is having 4 surfaces. This is the superior surface between the median umbilical ligament or apex and openings of the ureters on either side. And this is the base or posterior surface, which is present between the 2 ureter openings on lateral angles and urethral opening on the inferior angle. And lateral surface is present between the ureteral opening, the apex, and the urethral opening. So this is the lateral surface. On another side, on the other side also will be like this only. So apex, this one is the lateral, angle, and then base. So that is the lateral surface. So it is having a superior surface, a base, and two lateral surfaces. Now apex is directed forward to the upper part of the symphysis pubis and gives attachment to the median umbilical ligament which extends up to the umbilicus. So apex is forward and toward the symphysis pubis, it gives attachment to the medial umbilical ligament which is going to get attached to the umbilicus. Now base is the posterior inferior surface of fundus. It is directed backwards and downwards and triangular in outline between the two ureteric openings and urethra. So base is backwards, downwards, and it's triangular in shape between two ureteric openings, 1 and 2, and then the urethral opening. In most sexes, the base is non-peritoneal except in male where its upper part is covered with peritoneum up to the upper end of the seminal vesicle. Non-peritoneal area of the base is known as external triangle. So this base is non-peritoneal, but in male a part of the upper part of it is covered by peritoneum up to the openings upper end of the seminal vesicles. So here. So this is the base, this is the upper part of the base. This part is covered by peritoneum up to the upper part of the seminal vesicles, ductus. This is the seminal glands. So up to here it is covered by the peritoneum and lower part is not covered by peritoneum. It is called external triangle. Relations. In male, ampulla of rectum which is separated in the upper part by rectovesical pouch and in the lower part by the following structures. So it is related anteriorly, posteriorly, posteriorly to the rectum, and in between the rectum and this urinary bladder we are having rectovesical pouch in the upper part, and in the lower part we are having a pair of seminal vesicles, ampulla of vas deferens passing medial to the vesicles, rectovesical fascia which is derived from the fusion of primitive rectovesical pouch in the peritoneum, pouch of the peritoneum. In the female, upper part of anterior vaginal wall, anterior surface of supravaginal part of cervix. These are the surfaces, structures separated by the from the bladder by loose airway tissue. So in the male, it is the rectum that is in relation to the posterior surface of the bladder, and this rectum is separated from the posterior surface of the bladder in the upper part by the rectovesical pouch and in the lower part by a pair of seminal vesicles, ampulla of vas deferens, and ampulla of vas deferens passing medial to the vesicles. So here this is the male pelvis, what do you call the coronal section of the male pelvis, wherein you are seeing the urinary bladder. Then this is the rectum, sigmoid colon rectum, and that means this is the anterior part, and this is the posterior part, and this is the anterior part. See, pubic symphysis is anteriorly, and the posterior surface or base of the uterus, base of the bladder, is related to the rectum. So here, this part of the area between the rectum and urinary bladder, we are calling it as rectovesical pouch. This is the peritoneal extension in between the rectum and the urinary bladder, which we are calling it as rectovesical pouch. And below that, we are having the seminal vesicles and the part of ureter. So these are the seminal vesicles and a part of ureter. Then in the female, the bladder is related to the upper part of the cervix, vagina, and lower part of the uterus and cervix. So this posterior surface of bladder. Posterior surface of bladder is related to the lower part of the uterus and cervix and the upper part of the vagina. Now neck. It is the lowest part of the urinary bladder where the urethra begins. It is situated about 3 to 4 centimeters behind the lower part of the pubic symphysis. So this is the urethra, this is the lower part of the bladder, and this is beginning 3 to centimeters behind the lower part of the pubic symphysis. It is pierced by internal urethral orifice. In male, the neck rests on prostate gland. In female, it is related to the pelvic fascia that surrounds the upper part of urethra. So in the male, it is surrounded this, urethral opening is surrounded by the prostate gland. Whereas in female, it is resting only on the fascia. Pelvic fascia, okay. Now superior surface. It is triangular in shape between the two ureteric orifices and apex and mostly covered with peritoneum. Sigmoid colon coils of small intestine and in female anterior surface of anteverted uterus is in relation. So here again I am showing this is the bladder and this is the superior surface, this is the posterior surface, and of course we are having one lateral surface on this side and another on the other side. Then the posterior surface is in relation to the upper part is related to the rectovesical pouch, that is between the rectum and bladder, whereas the lower part is related with the seminal vesicles and part of ureter. And now the superior surface is covered by the peritoneum and is related to the coils of intestine in male, whereas in female the posterior surface, is in relation with the upper part of the vagina and lower part of the uterus and cervix, and the superior surface is in relation to the anteverted uterus, that means the body of the anteverted uterus. Inferior lateral surface. Okay, here also we have to uterovesical pouch. This is the uterovesical pouch between the uterus and the urinary bladder. This is also in relation to the anterior surface, superior surface. So superior surface is separated from uterus by uterovesical pouch. Then inferior lateral surface. Each surface is directed downwards and laterally and mostly non-peritoneal. This inferior surface is downwards and laterally, it is not covered by peritoneum. Relations: pelvic surface of the body of pubis and symphysis pubis. Fascia covering the levator ani and obturator internus, and the above mentioned structures are separated from the bladder by a potential space of Riccius, which contains retropubic fat and plexus of vesical veins. So this lateral surface is related to the pelvic surface of the body of pubis and symphysis pubis, and then it is related with the fascia covering the levator ani and obturator internus muscles, and these muscles are separated from the bladder by a space of Riccius. Is a potential space which is occupied by fat and plexus of vesical veins. Space of Riccius is a horseshoe-shaped space which intervenes between the anterolateral pelvic wall and sides of the bladder and prostate. So, in between the anterolateral pelvic wall and sides of the bladder, we are having space of Riccius. Surgical approach to the bladder is performed through this surface when the bladder is distended. So surgical approach of the bladder is through lateral surface when the bladder is distended. So this is the space of Riccius between the lateral wall of the bladder and lateral surface of the pelvis. Of course, here there are after internus muscle, and then we are having pelvic fascia is there, and of course there is the pubic symphysis. So this horseshoe shaped space is the space of ridges. Anterior border. Anterior border extends from the apex to the neck of the bladder and separates inferior lateral surfaces from each other. So anterior border. So this is the anterior border from the apex to the neck of the bladder. So this is separating the two inferior lateral surfaces. Posterior border. It separates the superior surface from the base and extends between the entrance of two ureters. Lateral border. Each border separates the superior surface from inferior lateral surface and extends from entrance of the ureter to the apex of the bladder. So here now we have seen the anterior border from the apex to the bladder neck, whereas the posterior border is separating the superior surface from the base. So this is extending between the two ureter. So this is the posterior border, and then lateral border is extending from the apex to the ureter on either side, one side and this one. So these are the two lateral borders, and this is the posterior border. This is the anterior border. Neck. Anatomically, the neck of the bladder is defined as the lowest point from which urethra begins. I have shown you there. It is situated about 3 to 4 centimeters behind the lower border of symphysis pubis. In the male, the bladder neck is surrounded by the base of prostate. In the female, it lies at the lower level and comes in contact with the superior fascia of urogenital diaphragm. Physiologically, the bladder neck includes entire female urethra and prostatic part of the male urethra, because detrusor muscles of the bladder extends up to this level. So physiologically, the bladder neck includes entire female urethra, whereas in the male it is prostatic part of the urethra. The wall of the urinary bladder consists of outer serous layer, a thick coat of smooth muscles, and mucous membrane. So this wall is having only three layers: a thick smooth muscle, outer serous layer, and inner mucous membrane. Trigonum vesicae, that is internal trigone, is equilateral triangle on the inner aspect of the base of the bladder, where the mucous membrane is tense and glistening due to the absence of submucous coat. In the male, a rounded elevation known as uvula vesicae projects upwards behind the urethral orifice and is formed by the median lobe of prostate. The uvula lies within the sphincter vesicae. Boundaries of trigone. Apex is directed downwards and forwards and is formed by the internal urethral orifice, which is crescent shaped. Base is formed by interureteric ridge, which extends between the orifices of two ureters. It is slightly curved transverse ridge and is formed by prolongation of inner longitudinal muscles of ureters. In an empty bladder, the greater part of the mucous membrane forms irregular folds. Each posterolateral angle of trigone presents ureteric orifice, which is an oblique slit. The orifices are about 2.5 centimeters apart when the bladder is empty, and it may be about 5 centimeters apart when the bladder is full and distended. A ureteric fold of mucous membrane extends upwards and laterally from each ureteric orifice and indicates intravesical course of ureter. Sides of trigone are formed by urethro-ureteric lines. Structure of trigone. From within outwards, it is a mucous membrane of transitional epithelium which is tense, trigone muscles of Bell which replace the submucous coat and is adherent to the mucous membrane, a loose areolar tissue sheet as fascia of Valder, detrusor muscle of the bladder. So these are the 4 layers in the trigone, and starting from interior, that is mucous membrane, then trigone muscles of bell, then looser sheet, and detrusor muscle outermost. So this is the trigone between the two ureter and the opening. We are having not much described here. So we are describing the prostatic part of urethra, and then prostate gland, neck of the bladder, and then we are showing the internal trigone between the neck of the bladder and two urethral openings. And of course, in the bladder wall, we are showing the detrusor muscle. Now, importance of the trigone. It is most fixed and dependent part of the bladder. Trigone is richly supplied with blood vessels and nerves. Trigone is developed from mesoderm by incorporation of the caudal parts of the two mesonephric ducts, whereas the rest of the bladder mucosa is developed from the ectoderm of the cloaca. So, the trigone is developed from the mesoderm of the caudal parts of the mesonephric duct, whereas the rest of the bladder is developed from the ectoderm of the cloaca. Arterial supply. The following arteries supply the bladder. The superior vesical artery, which is a branch of internal iliac artery. Superior vesical artery is a branch of internal iliac artery is one. It is non-obliterated part of umbilical artery. Superior vesical artery. Next is the inferior vesical artery, which is a branch of internal iliac artery. Then obturator artery. Then a branch from inferior gluteal artery and female uterine artery. So we are having superior and inferior vesical arteries, which are branches of internal iliac artery. Then we are having an obturator artery. Then we are having branch from inferior gluteal artery. Then of course in the female uterine artery. So these are the arteries that are supplying the bladder. Of course here we are showing the common iliac artery, this internal iliac artery, giving rise to superior and inferior vesical arteries. This is the inferior vesical artery and this is the superior vesical artery coming from the internal iliac artery. Then we are having the gluteal arteries. Of course, in the female, superior gluteal, inferior gluteal, uterine artery. This uterine artery is also supplying the bladder. Superior vesical arteries from internal iliac. Superior vesical artery from internal iliac. Then the inferior vesical artery also from internal iliac. Then obturator artery is there, which is supplying the urinary bladder. Then we are having superior gluteal and inferior gluteal arteries supplying the urinary bladder, and then we are having an uterine artery giving a branch to the bladder. Venous drainage. The veins form a vesical plexus which is situated along the inferior lateral surface of bladder in the space of ligatures. This plexus communicates below with the prostatic venous plexus in male and finally drains into the internal iliac vein through the posterior ligament of bladder. So the veins are forming a plexus along the inferior lateral surface in the space of ligatures, and these plexus will later drain into the internal iliac vein through posterior ligament of the bladder. Nerve supply. The urinary bladder is supplied by vesical plexus of nerves, which is made up of fibers derived from the inferior hypogastric plexus. The vesical plexus contains both sympathetic and parasympathetic components, each of which contain motor or afferent and sensory or afferent. So we are having a sympathetic component, a parasympathetic component. Again, in each one there is a motor or afferent and sensory or afferent. Then we are having the parasympathetic. This is all sympathetic only. Now parasympathetic afferent fibers of nervi irrigantes S2, S3, S4 are motor to detrusor muscle and inhibitory to sphincter vesi vesicae, that is nerve of emptying. Inhibitory to sphincter vesicae means the sphincter vesicae, which is usually contracting, will dilate, whereas motor to detrusor means it will compress. So the urine will come out. So the parasympathetic effect on the urinary bladder is emptying. Now, if these are destroyed, normal micturition is not possible, with a consequent retention of urine and overflow incontinence. Now, sympathetic afferent fibers from T11 to L2 are said to be inhibitory to the detrusor and motor to the sphincter vesicae and therefore acts as nerve of filling bladder. So here the sympathetic fibers are inhibitory to detrusor muscle and motor to sphincter vesicae. So motor means they are stimulating, that means the sphincter vesicae is contracting, at the same time the detrusor muscles are relaxing. So this sympathetic effect is allowing the bladder to get full. So we are calling this nerve of filling. Now, however, sympathetic nerve supply to the bladder is relatively unimportant because bladder function is not significantly affected by resection of hypogastric nerve. So, sympathetic nerve, even if it is cut also, function of bladder is not affected. The somatic pudendal nerve supplies the sphincter urethra, which is voluntary. So, we are having a pudendal nerve, which is supplying the urethra, which is under voluntary control. Now, sensory nerves. Pain sensations caused by distension or spasm of bladder wall are carried mainly by parasympathetic nerves and partly by sympathetic nerves. In spinal cord, pain arising in the bladder passes through the lateral spinothalamic tract, and awareness of bladder distension is mediated through posterior cords. Bilateral anterolateral cordotomy therefore selectively abolishes pain without affecting the awareness of the bladder distension and desire to micturition. So bilateral anterolateral cordotomy, that is lateral spinothalamic tract, if it is cut, it will abolish the pain, but the sensation of bladder distension will be there. So desire to micturition is also there. Clinical anatomy. A distended bladder may be ruptured by the injuries of lower abdominal wall. Peritoneum may or may not be involved. So, when the bladder is distended, it is pushing the peritoneum up. No? So, peritoneum, if it is by the pressure of blow, if it is broken, there is a chance that the urine may come into the peritoneal cavity also. Otherwise, it will be outside the peritoneum cavity only. In the chronic obstruction to outflow of urine by an enlarged prostate or by a stricture of urethra, there is a chronic obstruction of the urine by prostatic enlargement or stricture of urethra. This causes hypertrophy of bladder leading to trabeculated bladder. So chronic obstruction, that means there is a pressure on the detrusor muscle. So detrusor muscles will be hypertrophied and trabecula will be forming in this bladder. The interior of bladder can be examined in the living by cystoscope. So cystoscope can be introduced to examine the interior of the bladder. In the operations of suprapubic cystostomy, the bladder is distended with about 300 ml of fluid. As a result, anterior aspect of the bladder comes into the direct contact with the anterior abdominal wall and can be approached without entering the peritoneal cavity. So, suprapubic cystostomy can be done only after distending the bladder with a 300 ml of fluid such that the anterior abdominal wall is in direct contact with the bladder and you can put a trocar there. Now, urinary incontinence is emptying of bladder is essentially a reflex function involving the motor and sensory pathways. So, the emptying of bladder is essentially a reflex function involving motor and sensory pathways. Voluntary control over this reflex is exerted through upper motor neurons, and as long as one pyramidal tract is functioning normally, control of bladder remains normal. Acute injury to cervical or thoracic segments of spinal cord leads to a state of spinal shock. The muscles of bladder is relaxed and sphincter vesicae are contracted, but sphincter urethrae relaxed. The bladder distends and urine dribbles. After a few days, the bladder starts contracting reflexly when it is full. It contracts every 2 to 4 hours. This is automatic reflex bladder. Damage to the sacral segments of spinal cord situated in the lower thoracic and lumbar vertebrae results in autonomous bladder. The bladder wall is flaccid and its capacity is greatly increased. It just fills to the capacity and overflows. So there is a continuous dribbling. In the sacral cord injury, there is a continuous dribbling. Now other bladder conditions, cystitis, that is the inflammation of the bladder causing acute or chronic pain, discomfort and urinary frequency. So in cystitis, that is inflammation of the bladder due to infection, we are saying there is a chronic pain, there is a discomfort and urinary frequency or hesitancy is there. Urinary stones may form in the kidney and travel down to the bladder. If kidney stones block urine flow to or from the bladder, they can cause severe pain. Bladder cancer. A tumor in the bladder is usually discovered after blood is found in the urine. Cigarette smoking and workplace chemicals exposure to is causing the most of the bladder cancers. Urinary incontinence is uncontrolled urination which may be chronic. This can result from many causes. Overactive bladder. The bladder muscles squeeze uncontrollably, causing some urine to leak out. Tetrasar overactivity is a common cause of urinary incontinence. Hematuria. Blood in the urine. Hematuria may be harmless or may be caused by infection or serious condition like bladder cancer. Urinary retention. Urine does not exit the bladder normally due to the blockage or suppressed bladder muscular activity. The bladder may swell to hold more than a quart of the urine, that is half liter. Cystoscale, weakened pelvic muscles, usually from childbirth, allow the bladder to press on vagina. Problems with urination can result. So pelvic muscles, if they allow bladder to press onto the vagina, there is a problem of urination. Bedwetting, nocturnal enuresis. Bedwetting is defined as a child of age 5 or below who wets the bed at least 1 or 2 times a week over at least 3 months. So, if by chance once the boy or child below the age 5 wets the bed, it is not a bedwetting. It is not a nocturnal enuresis. It is defined as nocturnal enuresis when the child makes his bed wet at least 2 to 3 times a week over a period of 3 months continuously. So you can't call every bedwetting a nocturnal enuresis unless otherwise he is doing it twice or thrice in a week for a period of 3 months. Dysuria, painful urination, pain or discomfort during urination due to infection, irritation or inflammation of the bladder, urethra or external genitals. This is pain of urination. So that finishes our bladder. So the bladder mainly, what is the position of the bladder? Bladder is in what you call empty bladder, empty undistended bladder is present behind the pubic symphysis and its lower end is just above the level of lower part of pubic symphysis. Then the shape, bladder is a tetrahedral shape, that means a pyramid with 4 triangular surfaces, one superior triangular surface, one posterior triangular surface and 2 lateral triangular surfaces. The superior surface is defined between the apex and 2 lateral urethral openings, whereas the posterior surface is between 2 lateral urethral openings and the urethral opening, and the lateral surface is between the apex, urethral opening and urethral opening on either side. So we are having 4 angles, 4 borders, the 2 lateral borders, the apex anterior border between the 2 lateral surface and the posterior border between the superior surface and the posterior surface. So we are having 4 borders, 4 surfaces, superior surface base and 2 lateral surfaces, and 4 angles, that means the apex, 2 lateral angles of 2 urethral openings and the urethral opening. So that's the structure of the description of the bladder. And then bladder is having an internal trigone and the bladder wall is having mucous membrane, then the muscles and the serosa. And okay, that almost reaches the bladder. And of course, the clinical aspects of bladder are many because of its nerve supply and distension, workflow, then cystitis, all these things are there. And now we go for the ureter and urethra. So here we are showing this is the ureter starting from the pelvis of the kidney and going till it reaches the bladder. So this ureter will be having three constrictions. One from the starting point, that is at its junction with the pelvis, renal pelvis, and the another is where it is causing the bony pelvic brim. So here also, and one more is at the entrance of the into the ureter into the bladder and in the bladder wall. It is passing in the bladder wall to some extent, such that when the bladder is distended, this ureteric orifice is pressed and it is closed. Now, the ureter are a pair of thick-walled, narrow muscular tubes of excretory system. So, the ureters are a pair of thick-walled, narrow muscular tubes of excretory system. Then, whose peristaltic contractions convey urine from the kidneys to the urinary bladder. So, the peristaltic contractions of the ureter convey urine from the renal pelvis of the kidney to the urinary bladder. This measures about 25 to 30 centimeters in length and diameter is 3 millimeters, very small diameter. Diameter is 3 millimeters only and the length is 25 to 30 centimeters. Extension, they are extending from renal pelvis superiorly to the opening into the urinary bladder. This is the starting point, renal pelvis and opening into the urinary bladder. Okay, you can say this is about the length is about 25 to 30 centimeters and the lumen is about 3 millimeters. And location, upper part on the posterior abdominal wall deep to the peritoneum, lower part on the lateral wall of the pelvis. And then constrictions, we told you, at the pelvic-ureteric junction, that means near the renal pelvis where the ureter is starting, first one. Second one is at the pelvic brim, on the pelvic brim where it is passing into the pelvis. And the third one is at the entry of urinary bladder where it is entering into the wall of the urinary bladder. So this is at the renal pelvis, then this is at the pelvic brim, and finally at the place where it is entering the urinary bladder. The wall of the ureter is composed of three layers. The lumen is star-shaped when it is empty. Mucosa, the inner layer made up of urothelium and transitional epithelium. So the mucosa of the ureter, of course, ureter, urinary bladder, these are all made up of urothelium. What is this urothelium? It is a transitional epithelium. I think you still remember about the epithelia you have read. So in the transitional epithelium, what we are having is the innermost layer is having umbrella cells, which are wider such that they can cover two cells of the layer below that. It is also almost a stratified epithelium, but the difference is the innermost layer, that is the layer that is exposed to the lumen or exposed to the cavity are covered by umbrella shaped cells which can cover two or three cells in the layer below it. So these cells, they will change their shape according to the size of the lumen such that they will not allow seepage of urine through that epithelium to the layers below even when it is distended. That is the specialty of this transitional epithelium or urothelium. Then muscular. So first one is the mucous layer, then the muscular layer, it is inner circular and outer longitudinal smooth muscle layers. Then adventitia, that is the outermost layer, is having blood vessels and connective tissue. So it is having three layers. Mucosa, very special, that is covered by transitional epithelium with umbrella shaped cells, the innermost cells. Then the muscular layer, which is having inner circular and outer longitudinal layers. Then the adventitia, that is the serous layer with connective tissue and blood vessels. So here we are showing this is the mucous layer, which is having transitional epithelium with umbrella shaped large cells innermost and smaller cells outside. This is almost a type of stratified epithelium with special cells as their innermost layer. Then we are having this is the muscularis, and then we are having that is the inner circular and outer longitudinal. This is the outer longitudinal bundle, this is the circular bundle, and of course we are having serosa with blood vessels. Then arterial supply. The ureter is supplied by branches from renal, gonadal, common iliac, interiliac, vesical, and uterine arteries. So these are the names of the renal, that is from kidney, gonadal from the gonads, common iliac, interiliac, vesical, and uterine. So these are all the branches that can give you, that are giving branches to the ureter. Then venous drainage is from corresponding veins. Urethra. Urethra is a tubular passage through which urine is expelled out from the urinary bladder. So, the organ that is allowing the urine to go through it from the urinary bladder to the exterior, we are calling it as urethra. It is present in both male and female. Male urethra is about 18 to 20 centimeters long. It is a common passage for both urine and semen. It starts at internal orifice of urinary bladder, ends to the external opening or meatus at the end of the penis. So, this is the male urethra where we are showing it is starting at the internal opening, that is at the base of the bladder, and it is passing through the prostate, then it is passing through the pelvic fascia and passing into the penis, and then it is going out. Again here we are showing this is the membranous part of the urethra, then the prostatic part of the urethra, and penile part of the urethra. So we are having three parts. And then we are having a sphincter at the internal opening and a sphincter at the external opening. External urethral sphincter, this is the external urethral sphincter, and this is the urethral sphincteric muscle, that is the internal urethral sphincter. This is extending all this one. The male urethra is divided into four parts: pre-prostatic, that is intramural part, prostatic, then membranous, then spongy urethra. So this is pre-prostatic and this is prostatic. This small part is the membranous and this is the spongy urethra or penile part of the urethra. So we are having four parts in the urethra. Pre-prostatic, that is in between the bladder and prostate, then prostatic, then membranous between the prostate and the penis, that is the, and then penile part. This part is the membranous part of the urethra. So we are having here pre-prostatic, prostatic, membranous part, very short, least dilatable and narrowest part from the prostate to the bulb of the penis, and then spongy part that runs along the length of the penis, 15 centimeters, 1.5, 1.5 like that. Okay. Prostatic part is 3 centimeters. Then sphincters of urethra. It has two sphincters. Internal urethral sphincter surrounds the internal urethral orifice made up of smooth muscles, and it is involuntary. So internal urethral sphincter is involuntary. Whereas external urethral sphincter surrounds the external urethral orifice and is made up of skeletal muscle and is voluntary. So external urethral sphincter is voluntary, whereas the internal urethral sphincter is involuntary. Blood supply, the urethral artery arises from the internal pudendal artery or common penile artery and dorsal penile artery. Okay, we are having blood supply from urethral artery and dorsal penile artery. So that is the male urethra. Male urethra starting at the bladder, which is having the internal urethral sphincter at the bladder, and then this is the pre-prostatic part of urethra and prostatic part of urethra, and this part is the membranous part of the urethra, and this is the penile part of the urethra. Same thing. Okay, now in the female urethra, it's about 4 centimeters long and 6 millimeters in diameter. It is a passage for only urine, whereas in male it is urine for and semen, whereas in female it is only for the passage of urine, and it starts at the internal urethral orifice. The external urethral orifice is in the vestibule of the vagina. They is supplied with the vesicle and vaginal arteries. Venous drainage is through vesical plexus around the bladder neck. So that's about the urethra in female and male. And you are having ureter. Urethra, in male urethra, you are having four parts: pre-prostatic, prostatic, membranous, and spongy urethra. That is the penile part. Whereas ureter, in the ureter, which is starting from the renal pelvis and ending in the bladder, and these are about 25 to 30 centimeters length and 3 millimeters diameter, and they are having three constrictions. One is at the pelvic junction, and the another is at pelvic bones brim, and the other is at the entry of the urinary bladder. So here, this is at the pelvic junction, at the pelvis, and at the entry of the urinary bladder. Okay, of course, urinary bladder we have just finished, and now we go for the skin as excretory organ. See, skin is having sweat glands which secrete fluid, waste, and which is called sweat. Its role as a part of excretory system is minimal. The sweating also maintains the level of salt in the body. In mammals, the skin excretes sweat through the sweat glands throughout the body. Sweat, helped by salt, evaporates and helps to keep the body cool, and of course when it is warm. Now, eccrine type of sweat glands. Like sweat glands, these eccrine glands allow excess water to leave the body. Majority of the eccrine glands are located mainly on the forehead, the bottoms of the feet and palms, although the glands are everywhere throughout the body. They help the body to maintain temperature, and then eccrine glands in the skin are unique to mammals. Secretion of sweat from the eccrine glands play a large role in controlling the body temperature of the humans. Then regulation of body temperature is also known as thermoregulation, which is very important. Then there are three parts to the eccrine sweat glands. These are pore, duct, and gland. The pore is the portion of that goes through the outermost layer of the skin, and that is typically 5 to 10 microns in diameter. The duct is the part of sweat gland that connects the dermis cells to the epidermis, and it is composed by two layers of cells and is between 10 to 20 microns in diameter. The gland does the actual secretion and it lies deep to the dermis. Apocrine sweat gland. These are large sweat glands. Unlike eccrine glands, they discharge their secretion into the apical region of the hair follicle. These glands are present only in few parts of the body, like axilla and perineal region. So, sweat glands are Acrine, apocrine type. Apocrine are present only in the regions like the armpits and axilla and perineal region, and the acrine sweat glands are present in the forehead, the palm and soles, where more amount of sweat can be released, and this will be useful in regulating the temperature of the body when the body becomes heat. And usual sweat glands are present everywhere in the skin, and they are secreting their secretion to go out, and with minerals and water is also going out, and the evaporation of this sweat also is leading for the control of the body temperature. Okay, now we'll see a section of the skin, and then so here I am showing the section of thick skin, wherein you will be seeing these coveted cells on the outside, then stratum corneum, then we will be seeing a stratum lucidum, a area with almost empty space like this, and then stratum granulosum, then the stratum spinosum, and finally stratum basalis. So we are having stratum basalis, stratum spinosum, stratum granulosum, stratum lucidum, stratum corneum, 5 layers in the thick skin. And in thin skin, we are having stratum corneum, then the stratum spinosum. That means here we are seeing no stratum lucidum and no stratum granulosum. And finally, we are having the stratum basal and dermis. In the dermis, we are having this hair follicle, and by the side of hair follicle, we are having the sebaceous glands, and of course, they are pouring their secretion into the hair follicle itself. Whereas we are seeing the sweat glands and their excretories and distributed in the skin only, and they are present in the dermis, and their pore is coming onto the epidermis. So we don't have a sweat gland particularly, but sweat glands are present in the dermis, and they are excreting their secretions into the epidermis. And I told you the sweat glands can excrete water as well as some minerals, and some apocrine sweat glands that are particularly present in the armpit and the pelvic region, the perineal region. They are excreting some odorous, substances through their secretions, which is important in some physiological functions. So that finishes your skin as a excretory organ, the urinary bladder, the urethra, ureter, and almost all your excretory portion.